Thank you, and I'd like to start by thanking you all early birds who got up and came to be with us today. Really value your presence. I will present an unusual case of an augmented benign vascular tumor, and we'll see how far the laser took us in this case. As you know, vascular tumors are caused by the neoplastic transformations of cells constituting vascular structures. And traditional therapeutic options include surgical resection, embolization, physical modalities such as laser therapy, and medical treatments such as corticosteroids, beta blockers, and chemotherapy. Ours is a case of a 20-year-old healthy man who was referred to our laser unit due to rapidly growing facial vascular lesions. 2 months earlier, he had experienced a small superficial burn from a welding accident on his left nose bridge. 2 weeks later, an erythemic nodule appeared in the same location. Initially, dacrocystitis was suspected. During an attempt at drainage, significant bleeding occurred, and the patient was treated with electrocoagulation, followed by a course of oral augmentin. Despite these measures, the lesions continued to spread towards the forehead, the nose, and the eyelids, as nodules and superficial papules continued to appear and evolve on a slightly erythemic background. At this point, we performed a thorough laboratory investigation. It included a complete blood count, wide panel of chemistry, and serology for HIV, hepatitis B virus, and hepatitis C virus, and they were all within normal limits. A biopsy demonstrated dermal vascular proliferation of closely packed endothelial cells, forming dilated, somewhat angulated capillaries with plump endothelial cells. Focally, on the surface, a lobular growth pattern could be observed, correlating with the clinically like pyogenic granuloma areas. There was no endothelial atypia or multilayering. The tumor was diagnosed as unclassified benign hemangioma. MRA and MRV imaging demonstrated a subcutaneous exophytic homogeneous mass on the left side of the nose and the upper eyelid, and there was no bone or orbital invasion. The vascular mass had no major feeding vessels and no underlying vascular malformation was noted. The diagnosis was eruptive disseminated pyogenic granuloma. Pyogenic granulomas are usually solitary, but multiple lesions, also referred to as satellitosis, can occur after initial surgical removal or following a burn, just like in our case. Multiple localized pyogenic granuloma-like lesions are termed augmented pyogenic granulomas and may follow an aggressive clinical course. Again, just like in our case. This case is unusual. It showed a focally superficial component with lobular architecture on pathology and clinical behavior simulating augmented pyogenic granuloma in association with diffused, acquired, unspecified capillary hemangioma. And this is a unique pattern previously unreported. Initially, the patient was started on 60 milligrams of prednisone per day with gradual tapering down. He also received 30 milligrams of propranolol 3 times daily, but there was no apparent improvement. There was no response. At that point, the patient was put on rapamycin, but once again, there was no response, and the patient was referred to laser treatment in our unit. We treated the patient with a combination of radiofrequency thermal ablation, long pulse Nd:YAG laser with these parameters for the nodules, for the nodular lesions, and pulsed dye laser with the specified parameters to the small superficial papules. Repeated once to twice weekly sessions took place for 3 to 4 weeks, but despite our best efforts, there was no improvement. The tumor continued to grow and continued to spread. At that point, we stopped to think, what can we do next? At this point, both conventional medical therapy and conventional physical modalities have completely failed. So, what can we do? One suggestion was to surgically remove this mass. And although we thoroughly considered it, we rejected that option due to 2 main reasons. The first one is that the anticipated aesthetic outcome would have been totally unacceptable. And the second one is that there is a huge risk of recurrence following such a procedure. So, what's left? The investigation of genetic mutations underlying vascular anomalies has recently proved new insights into the genetic etiology of these lesions, giving rise to personalized, targeted medical treatment that may potentially be safer and more effective than conventional therapies. So we performed next-generation sequencing on the formalin fixed tumor, and we had identified a mutation at the 61 codon of the NRAS gene with a variant frequency of 8%. We offered the patient an off-label compassionate treatment with dramatinib, a MEK inhibitor. And following his consent, treatment was initiated at a standard dose of 2 milligrams a day. With only 1 week from the treatment, the skin looked much better, with skin lesions reduced in quantity and in bulk. Follow-up evaluation, which included blood pressure measurements, complete blood count, chemistry, lipid profile, echocardiography and echocardiogram, and ophthalmological examination were all within normal limits. The patient had no severe adverse events, although he did experience some mild ones, an acneiform rash, as you can see, mild paronychia, and mild asthenia. 3 months after the initiation of therapy, lesions were almost resolved with only a slight remnant evident on the left upper eyelid. Recent discoveries have uncovered the role of hyperactivation of the RAS mitogen-activated protein kinase extracellular signal-regulated kinase pathway in vascular anomalies as well as in vascular tumors and in other neoplastic conditions. And we know that pyogenic granuloma may harbor mutation in RAS genes. In a work by Lim and colleagues, 6 specimens out of 42 sporadic pyogenic granuloma showed mutations in KRAS, NRAS, or HRAS genes. And in another work by Grosser and colleagues, mutations in BRAF and KRAS were also found in specimens of pyogenic granulomas arising on port wine stains. NRAS is one of the 3 major isoforms of the RAS family of GTPase proteins. And almost 60% of NRAS tumor harbor mutations at codon 61, just like in our patient. 35% harbor mutation at codon 12. This is a unique case of reactive aggressive vascular proliferation simulating aggregated pyogenic granuloma with NRAS mutations. When conventional medical therapy failed and vascular lasers and thermal ablation didn't prevail, a MEK inhibitor was initiated with an excellent response. And my take-home messages from this case is that even though we're all laser people, we should be open to the possibility of other therapeutic options when applicable. It's never easy to present your failures, and this is definitely a failure of laser treatment. However, we were open to other possibilities, and thanks to that, there was a successful treatment in this patient. And this case also highlights the potential of targeted therapies in the context of vascular lesions. And the future is definitely still to come. I would like to thank all the physicians involved in treating and evaluating these patients, all my colleagues. And I would like to thank you for your time, for your attention, and especially for getting that early in the morning and being with us. Thank you very much.
Thank you. Thank you, Professor Levy.